In this lecture, we're going to analyze everything we've learned so far and see how we can put it together in the clinic. So clinical genetics, as we've learned in one of our previous lectures, is the application of all of this genetic knowledge and then transferring it into clinical management for patients who come and see us or seek counseling from us. There are multiple issues to consider in genetic counseling, and we're going to talk about if you do become a genetic counselor or if you're liaising with someone who is a clinical geneticist, that how do you actually take a patient through all of this complex information, what's the benefit for you, and what are the skills that are needed for a successful appointment as a clinical geneticist or a genetic counselor. These are the topics that we're going to be covering in this particular lecture. So what is genetic counseling? It is defined as a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So we do have to consider the medical risks for the patients as well as for the family members. So in genetic counseling, as opposed to many other professions, you're not only giving a diagnosis to the patient, you're potentially telling them that there are many other people within their family who may be at risk of developing the same condition. So it's a lot more complicated in terms of not just the medical impact, but also the psychological and emotional impact for people, because the unit that you're actually dealing with here is not a single patient, but it's a family unit. In a genetic counseling session, we also facilitate informed choice and adaptation to the risk or condition. So there is no compulsion for them to undergo genetic testing or not undergo genetic testing, and it's actually quite complicated in terms of family communication, etc. So it's really important for us to navigate that and have the skills to understand what our clients really want. We don't treat them as in a paternalistic way where we say you don't have to do certain things, or inform your patients, or you must have genetic testing or you must not have genetic testing. It's more allowing them the informed choice after giving them all of the options and after giving them all the information that is necessary for them to make that choice. And also, once they've made the choice, it's not simply, I told you have to make your own choice and now you have to adapt yourself, but also being available and helping them through the ongoing process of adaptation to such complex information, which not only affects them, but also many other family members. It could be their children or siblings or parents or extended family. So it is trying to involve all of those people as much as we can and helping the client in front of us to be able to cope with all of these complex processes that they have to go through. Genetic counseling can be provided by genetic counselors, or it can be trained physicians, which is clinical geneticists. So you are medically trained and you can calculate all of the complex possibilities and complex medical information, but also need to be trained to handle all of these complex information and be able to translate it in the right way to your patients and their family members. There are also genetic nurses which are employed in multiple departments to do genetic counseling for specialized conditions. So what are the aims of a clinical geneticist? Now, what is the aim in a clinical genetics counseling session? First and most important, you have to make a correct medical diagnosis. So you need to know what sort of genetic testing to choose, how to actually choose that, and you need to balance it with the costs as well. Genetic tests are not freely available everywhere in the world. In some places they are easily available, some places there may be costs that have to be passed on to patients, depending on the availability of funding, government infrastructure, hospital infrastructure, and availability of funds individually for patients and families. It's trying to choose the appropriate, at the same time, most economic test, and not wasting money, but at the same time not skimping on the type of test needed in order to bring out the correct diagnosis. Sometimes people have gone through a lot of investigations and we might be their last resort to try and find the correct diagnosis. So many times genetic testing can lead to precision diagnosis, you know that they've got a problem in a particular gene that definitely causes a particular condition. So many times that is where the diagnostic journey stops. And now, after years and years of trying to chase a diagnosis, many people, after having a genetic test, might finally arrive at the most precise diagnosis for them, but it also has a lot of other effects. Genetic testing is not very simple. Yes, ordering the test might be easy, but interpreting the results might be difficult, and we will go through the different issues in terms of interpreting a genetic result in one of the last slides. Once you interpret it, it's also important to know how to communicate genetic test results accurately. It can be quite complex. There are lots of issues that need to be considered before communicating the results to the patient. It's really important that they understand what they're getting themselves into by doing appropriate pre-genetic test counseling as well. Once genetic testing has been done and the results have been interpreted and communicated, we do need to then recommend appropriate treatment and management, including referrals to other specialist providers as needed. It's important that we institute psychologically oriented counseling to help the affected person and their family members understand and come to terms with the nature and consequences of the risk or the condition. It's also important to empower the patients to inform other family members of their potential risk. We don't see it as our job unless it is some very important conditions or life-threatening conditions, or potentially being required by law to do so. We don't necessarily go and inform family members directly behind the patient's back. We usually help the patients, empower the patients to then tell them to inform their own family members. It's also important to explain what approaches are available to the patient and family members to undergo genetic testing and or modify their genetic risks. So some of the conditions, for instance, like breast cancer, if they do find out that there is a particular gene, but their gene problem, but they're asymptomatic themselves, naturally the first question they want to ask is, what is the benefit? Why do I need to find out? How is this going to help me medically? There are lots of things that they can do if they do find out that they have a potentially high risk of breast or ovarian cancer. They can either have frequent surveillance in the form of mammograms or breast MRI scans, for instance, and pick up cancer very early on and undergo treatment to prevent any complications. Or some people might choose to have preventative surgery like mastectomy to preventatively remove their breast tissue to decrease the risk, or similarly also ovarian tissue to decrease the risk of ovarian cancer. So these are complicated things, but it opens up possibilities of prevention in many scenarios. But this is not necessarily the case for every single gene. There are some genes where there is no treatment, and the benefit might just be a psychological closure for the family members as well as the patient to find out what they've got, or in some cases to make appropriate life decisions in terms of employment or writing a will, for instance. So there are some tangible benefits, but there are sometimes people might realize that there are no tangible benefits and they might choose not to do these genetic tests after undergoing appropriate pre-genetic test counseling. So what are the benefits for the consultant? Consultant is a person who is seeking your genetic counseling. It's not necessarily an affected person. It could be a family member who just says, hey, my sister or my brother or my uncle has got this particular condition. They might come to you to get a bit more understanding of what it means for them and for their children, for instance. So what is the benefit for this consultant who is seeking genetic counseling? So a consultant, by coming and speaking to a clinical geneticist or a genetic counselor, can comprehend the medical facts, including the diagnosis, the probable course of the condition, and the available management of whatever is going on in their family. They can understand the way heredity contributes to the condition and the inheritance risks for themselves and for other family members. And they can also understand the available reproductive options for mitigating genetic risks. So we will talk about reproductive options that are currently available, but if it is an autosomal dominant or an autosomal recessive condition, some people might say, hey, this is a very high risk condition. I would prefer not to have a child with the same type of genetic condition. What are the options that are available? Is there anything I can do to prevent having a child like that? Is there anything I can do to actually have a healthy child? There are options that are available, and we will have to unpack all of this and help them understand the different options that are available for them. We also need to identify those values, beliefs, goals, and relationships affected by the risk for or presence of a hereditary condition. We also choose the course of action that seems most appropriate to them in view of their risk, their family goals, and their ethical or religious standards. We help them to make the best possible adjustment to the condition or to the inheritance risks for that condition, or both, by providing supportive counselling to families and making referrals to appropriate specialists, social services, and family and patient support groups. So genetic counselling appointments are quite involved. It's not like meeting with a cardiologist and just getting a medication for high cholesterol, for instance. This is quite complex and very time consuming. So usually the appointments are approximately an hour to sit down and have a chat, take a thorough family history, and understand the issues within the family, and help to give them all of the different equipment that they need to have to be able to cope with their own diagnosis, as well as the implications for family members. So what are the common indications for genetic counselling? People seek genetic counselling if there is a personal history or family history of a hereditary condition such as cystic fibrosis, Fragile X syndrome, or if there is a congenital heart defect with the suspicion that there might be an underlying genetic condition, or hereditary cancer, or even diabetes, particularly young onset diabetes, where there are some genes that we can test for, but also if all of the other diagnoses have, for the causes of a young onset diabetes, have turned out to be negative, a patient or their doctors, their specialists, might actually wonder if there is an underlying genetic problem, and they might refer them on to clinical genetic services. If they've had a previous child with multiple congenital anomalies, or intellectual disability, or an isolated birth defect such as neural tube defect or cleft lip or palate, people might then wonder, is there a risk for the next child they have as well, and they might seek genetic counselling. If there is a pregnancy at risk for a chromosomal or hereditary condition, the pregnant woman, or as well as her family, might seek genetic counselling to find out what this chromosomal or hereditary condition means for their child, their unborn child. If there is consanguinity, which means an identifiable common ancestor, like first cousins or second cousin marriages, and in this case, there is a slightly higher risk, particularly for autosomal recessive genetic conditions. And this couple might seek genetic counselling to find out what the actual risks are and what they can do to mitigate these risks. If there is an exposure to a teratogen, such as occupational chemicals or medications or alcohol, some people might seek genetic counselling to find out if this can affect the genes for their unborn child. If there is repeated pregnancy loss or infertility, after undergoing all other investigations, some people might come to us to find out if there is a genetic cause, like a chromosomal abnormality or a balanced translocation for the repeated pregnancy loss or for infertility. Some newly diagnosed medical conditions with genetic etiology, which other doctors may not be too familiar with. There are some very rare genetic conditions, and these patients might get referred on to genetic counselling services. Before pursuing genetic testing, and after receiving results. So this could be either genetic tests that are organized through genetics clinics, but there are also a number of direct-to-consumer genetic tests that are available these days. So people just spit in a jar and send it across to private companies. And these results may or may not be accurate, and some people might come before undergoing such genetic tests, direct-to-consumer type of genetic tests, and find out, is this the right thing for them to do, or should they not be doing that? Depending on their specific conditions, genetic counsellors can advise them accordingly. And after receiving such results, they could also come saying, look, this is the results I've got, and I don't really know how to interpret this. Could you help me interpret these results? that I've done privately, and we may or may not be able to always give them the accurate results depending on the type of test that was done, but we can at least talk to them about the pros and cons of such a genetic testing and find out their specific issues and organize appropriate genetic testing if necessary. They can also seek genetic counseling as follow-up for a positive result of a newborn test, such as with phenylketonuria. So if the newborn test has actually shown that the baby has got phenylketonuria, they might then seek genetic counseling to actually undergo genetic testing for themselves, for other children, as well as for the parents. Carrier testing is sometimes when there is a genetic condition running in the family, an autosomal recessive condition or certain X-linked conditions, the woman or the couple might come to us and say, I'm not sure if I'm silently carrying this particular gene, I just haven't manifested that, and therefore there might be an increased risk for my child. But couples might also come to genetic counselors because just in their community there is an increased risk for particular recessive conditions. For instance, cystic fibrosis is highly prevalent in the European population, European white population, and it may be that people of this community might then seek genetic counseling to find out if they should undergo carrier screening to check if they're a silent carrier for cystic fibrosis. There are also a number of private companies which offer carrier screening for hundreds of conditions, and some people might choose to have these sorts of expanded carrier screening tests, and they might seek genetic counseling at that time as well. A positive first or second trimester maternal serum screen or a non-invasive prenatal screen by cell-free fetal DNA analysis, which is the NIPT test, you may have heard of these, or abnormal fetal ultrasound examination results. All of these can lead to subsequent referrals to a genetic counseling service as well. So how do we determine recurrence risk if a person is determined to have a genetic condition? When a condition is known to have single gene inheritance, like an autosomal dominant condition or an autosomal recessive condition, the recurrence risk for the specific family members can usually be determined from basic Mendelian principles. So if you can look at the figure here, if I told you this is an autosomal recessive condition, what is the risk for the next child born to this couple? And if we know that both the parents are carriers for this particular recessive condition, then we can say the risk for the next child is 25% or 1 in 4. Risk calculations may be less than straightforward if there is reduced penetrance, which means a person has got the genetic problem, but they don't always manifest the genetic condition. So the penetrance of that particular genetic condition is not very high. Or there might be variability of expression. We've talked about these very early on in some of our lectures. Variability of expression means that a particular gene problem causes different conditions in different people. So using once again the example of BRCA1 or BRCA2 gene problem, if there is a person with a gene variant in BRCA1, they could either have breast cancer, or they could have ovarian cancer, they could have both, or they could have neither. So this is the variability of expression. Or if the condition is frequently the result of a de novo variant, if we know that this condition occurs, de novo means for the first time. So it is not necessarily inherited, but it has occurred for the first time in somebody. So these things can actually make it difficult for us to accurately predict what is going to happen to another person in the family. It also depends on accuracy and completeness of family history recall by the consultant, which is not always possible. When you actually see families, not everybody knows everything that has happened to every single person in their extended family. So that puts some constraint on how to actually interpret the results for the family members. Also, knowledge of genetic conditions is changing constantly. Therefore, it may be that what we know currently might change in the future, and we may sometimes need to recall those patients with the advent of that new information and inform them what that means for them as well as the family members based on the new information that we've gleaned. So what is the probability of being a carrier in an autosomal recessive condition? Let's take this example. There is one person who is affected by an autosomal recessive condition. We have now established that both the parents are carriers. So for both the parents, the chance that they're a carrier is 1. So it's a complete chance that they are carriers. But what does this mean for the siblings or first-degree relatives of people who are carriers? So let's take the mother. So what's the chance that the mother's sister is a carrier? Her chance is 50-50, right? She's either a carrier or she's not a carrier. So her chance is half. Similarly, the father's sister has got a half chance of either being a carrier or not being a carrier. What about the affected person's mother's parents? So the affected person's grandparents. They all also have a half chance of being or not being carriers, right? Now, what is the chance of the father's sister's child to be a carrier? Their chance is half of the mother, right? If the mother is a carrier, then they have a half chance of being a carrier. But once again, you have to apply the chance that the mother is a carrier herself. So they have a quarter chance of being a carrier. So this is not a chance of being affected. This is a chance of them being a carrier, which means they're silently carried in one of the alleles and they don't actually manifest the condition. But if they partner with somebody who's also silently carrying the same thing, then they have a 25% chance of having an affected child. Now, what is the probability of being a carrier in an X-linked condition? So let's say here there is a person who is affected by an X-linked condition, and in this case we've used an example of hemophilia A. Now, if that person is affected, then and we also know that person's daughter is definitely a carrier, right? So if the person is affected, they do have an affected X chromosome, and they only pass on the X chromosome to their daughters. So all of an affected person's daughters will be a carrier, right? So in an X-linked condition, the daughters of an affected male are always carriers. So this woman now has had 5 children, and none of her boys are affected, okay? Now she's also got a girl, and is this girl a carrier? How do we know? What is the chance of this girl being a carrier? If the mother is a carrier, which in this scenario she is, her chance of being a carrier is 50%. Either she's inherited the affected X chromosome or she's inherited the unaffected X chromosome. So her carrier risk is 50%. So risk estimation by use of Mendel's laws when genotypes are fully known. So when we know that everybody's genotypes, when we've tested everybody, it's a little bit easier to predict what the risk is for other people. So the simplest risk estimates pertain to conditions with simple Mendelian inheritance patterns. For example, if both members of a couple are known to be heterozygous carriers of a condition with autosomal recessive inheritance because of carrier testing, so we've done genetic testing for them and we found out that they're both silent carriers, then the risk or probability of an affected child is 1 in 4 with each pregnancy, even if the couple were to have 6 unaffected children, right? So let's say this couple has 1 child which is affected. Then they go on to have 6 children. So we can see scenario B here. They've had 6 children who are unaffected. Then they come to us and say, hey, we've had 1 child who is affected, but we've then had 6 children who are unaffected. So, what is the chance that our next child will be affected? Will our next child also be unaffected? No. For each child, the chance is 25%. For each of those 6 children they had who are unaffected, the chance was 25%. Of course, there was a 75% chance that they will not be affected. but there still remains a 25% chance for each pregnancy that the child will be affected if we know that both the parents are silent carriers. So what is the risk estimation by use of conditional probability when alternative genotypes are possible? What I mean by alternative genotypes are being possible is that we don't know the genotype of some people. So let's take this example in scenario C as listed here. So in contrast to the simple case just described, if the genotypes of the relevant individuals in the family are not definitively known, risk calculation is not easy. For example, the chance that a woman who has an offspring with cystic fibrosis, as depicted in this scenario C, with her first partner, what is the chance that she might have a subsequent affected child with another partner? So it depends on the chance that her next partner is a carrier of the pathogenic allele in CFTR. So here we know that there is a child who has got cystic fibrosis. We also know that both that child's parents were silent carriers. Now the mother has partnered with another person, and we don't know what the genetic risk in this other person is. So how are we going to find out if a child that she has with that other partner is at risk or not, given that she is a silent carrier herself? So the likelihood that the new partner is a carrier depends on his ancestry. For the general US non-Hispanic white population, the empiric risk, which means that based on a lot of studies, they know that there is a 1 in 22 chance of any random person, non-Hispanic white population person in the US is a carrier. So the new partner has got a 1 in 22 chance of being a carrier. Therefore, the chance that a known carrier and her unrelated partner would have an affected first child is the product of these two probabilities. So 1 in 22 chance for the new partner and 1/4 chance from her. So there is a 1 in 88 chance. So you can see that. So we've sort of calculated based on that. However, if we can test the second partner, we will find out if he is definitively a carrier or not and can give more accurate estimates. But it is not always possible, especially if it is a condition where the genetic variant is not known or is uncertain. So in these cases, when there is uncertainty in terms of genetic carrier status, we use Bayesian analysis using conditional probability. Let's use hemophilia A as an example. Let's consider the case of a female patient with 2 maternal uncles who are affected with hemophilia A, which is an X-linked condition. She is planning on having children and wants to know her chance of being a carrier. She does not want to have a genetic test herself, simply wants to find out what the risk of her being a carrier is. First, we list all possible alternative genotypes that may be present in the relevant individuals in the pedigree, and we'll go through that in the next slide. In this case, there are 3 scenarios, each reflecting a different combination of the alternative genotypes. Let's move on to the next slide so we can talk about it in more detail. So let's take scenario A. Okay, so you can see in this pedigree here, so the consultant is always marked with an arrow. So the consultant has 2 affected uncles, and she wants to know what her chance of being a carrier is. So there are different scenarios that are possible. Either the consultant's mother was a carrier herself, or maybe the consultant's mother was not a carrier. So the consultant, we don't know what her genetic scenario is at the moment. So if the consultant's mother was a carrier, then there is a possibility that she's inherited the genotype and is also a carrier, but there is also a possibility that she has not inherited the genotype and therefore is not a carrier. If the mother is not a carrier herself, then she wouldn't have inherited that. So she couldn't have, therefore there's only one scenario. If the mother is not a carrier, she's also not a carrier. So there is no scenario D here. So there's only A, B, and C, because if the mother is not a carrier, she's not a carrier either. All right, let's consider individually each of these scenarios. Scenario A is when our consultant's mother, who in here is generation 2, person 2, in other words, 2-2, let's consider that she is a carrier, but the consultant herself did not inherit the mutant allele. So if you take this scenario, we allocate a prior probability of her mother being a carrier, which is half, which simply means that the affected uncles, there are two affected uncles, therefore the consultant's maternal grandmother would be a carrier, right? So if the maternal grandmother was a carrier, then the consultant's mother had a half a chance of also being a carrier. So that's allocated as a prior probability. Now, if the mother was a carrier, then what is her chance? So that's the conditional probability. So the next level after prior probability, after allocating a condition, we take the conditional probability. Now she's got 4 unaffected brothers, okay? So that none of them, if they're unaffected, it means that they have not inherited that gene. So they've got all half a chance of not having inherited the affected copy, right? Because they only have one X chromosome. So if they did inherit it from their mother, they would manifest it. So let's give half a chance for all of them of having not inherited that. So we know that there's half times half times half times half, because it's occurred 4 times now in the family. There are 4 brothers and they're all unaffected. So it's half to the power of 4. Now let's take her chance. So we've assumed in this scenario that she did not inherit the mutant allele either. So she's got a half chance of also not being affected. So let's combine all of these probabilities. When we combine all of these probabilities, it's called joint probabilities. So half chance for her mother, and half to the power of 4 for all her brothers, and half a chance for herself. Now if you combine all of these, you get 1 in 64. So park this here. We'll move on to scenario B, and we'll come back to posterior probabilities once we finish the other 2 scenarios. In scenario B, let's assume that person 22 is a carrier and the consultant did inherit the mutant allele. Okay, so she's also a carrier. So in this case, the prior probability is still a half. The conditional probability, because she's got 4 unaffected brothers, is once again half to the power of 4, and there is a half a chance that she's a carrier. So it's the same probability. The joint probability is half times half to the power of 4 times half of her being a carrier. So this is a 1 in 64 chance as well. Park this. Let's move on to scenario C. Scenario C, we assume that person 22 is not a carrier, and so the consultant could not have inherited the mutant allele either. All right. So here the prior probability is half. If the mother is not a carrier, then none of the children would have inherited that. So what is the chance that all her boys would be unaffected? It's a full chance, which means a chance of 1 for each child. So 1 to the power of 4. And if the mother is not a carrier, what is her chance that she's also not a carrier? It's a full chance. So once again, it is 1. So the joint probability in this scenario is half times 1 to the power of 4 for all of the brothers, unaffected brothers, and 1 chance for her. So it comes out to be a half. Now let's take posterior probability for each of these scenarios. Posterior probability is what is the chance of this scenario occurring in amongst all of the scenarios, which means dividing the joint probability of each scenario with all of the combined probabilities. So taking scenario A, the chance is 1 in 64, and then you divide it by the combination of all of the joint probabilities. So 1 in 64 divided by 1 in 64 for possibility A, 1 in 64 for possibility B, and a half for possibility C. That gives us a 1 in 34 chance that she is not a carrier. Okay. So similarly, we calculate the posterior probability of her being a carrier, which is once again 1 in 64 divided by 1 in 64 from scenario A, 1 in 64 from scenario B, and a half from scenario C. So once again, we get a 1 in 34 chance that she is a carrier. Now, what about if her mother is not a carrier? What is her chance of then also not being a carrier? So that is a half a chance divided by all of the other probabilities. So 16 out of a 17 chance that she's also not a carrier. So the possibility of scenario A occurring is 1 in 34. The possibility of scenario B occurring is 1 in 34. And the possibility of scenario C is 16 in 17. So 3/5 chance of being a carrier based on Bayesian calculations is 1 in 64 divided by 1 in 64 plus 1 in 64 plus half. So she only wants to know scenario B, right? So what is the chance that I am a carrier, which comes out to be 1 in 34, in other words, approximately 3% chance. Taking into consideration the fact that she's got 4 unaffected brothers, we give her a 3% chance that she is a carrier. So what about in conditions with incomplete penetrance? So in the adjacent pedigree, what is the chance that the consultant, who is person 4 in generation 3, so 3-4, is heterozygous for the gene variant or mutation? So this is a condition, a pedigree of a family with split hand malformation, which has autosomal dominant inheritance with incomplete penetrance. Incomplete penetrance, once again, we've gone through that previously, means that a person may have inherited the gene mutation or the gene variant, but they may not necessarily show the phenotype. An estimate of penetrance from previous literature in split hand malformation shows us that there is a 70% penetrance, which means that if a person has inherited the gene variant, there is a 70% chance that they will show the phenotype, but there is also a 30% chance that they will not show the phenotype. Therefore, even if she has inherited the gene variant, there is a 30% chance that she will not have split hand malformation. So let's do the Bayesian calculation in this scenario. So this is a Bayesian calculation in an autosomal dominant condition with incomplete penetrance. There are two possibilities that person 3-4, since her mother is, for person 3-4, since her mother is affected. First, she may not have inherited the variant allele from her affected mother, or second, she may have inherited it, but is not manifesting the phenotype because of incomplete penetrance. So in scenario A, 3-4 has a prior probability of 1 in 2 of not being heterozygous for the variant. If she is not heterozygous for the variant, she has an essentially 100% or a full chance of not manifesting the phenotype. So the joint probability for scenario A is half, which is the prior probability, and multiply that by a full chance of her not being affected. In other words, it's a half chance or a 0.5 probability. So let's take scenario B. In B, person 3-4 is heterozygous for the variant, also with prior probability of 1 in 2. Here, however, we must apply the conditional probability that she is heterozygous for the variant but does not manifest the phenotype, which has a probability of 1 minus penetrance, in other words 1 minus 0.7, which is 0.3. So the joint probability for B is half times 0.3, which is 0.15. So what is the posterior probability here? That 3-4 is heterozygous for the variant without manifesting the phenotype, which is scenario B. The posterior probability here is 3 in 13. In other words, it's approximately 23% chance that she does carry the variant, but simply is not showing the phenotype. So genetic counseling for complex conditions which do not follow Mendelian patterns. So Mendelian is dominant, recessive, X-linked, or mitochondrial. So these are quite complex. Currently, we only give them empirical risks. Empirical means based on observations through large studies. It is possible that in the future, more personalized risk assessment can be provided using calculation of polygenic risk scores and environmental exposures. However, right now we don't have that equipment, then these things are not clinically validated yet, and we are still working on it. Genetic counseling for consanguinity. Consanguinity means presence of an identifiable common ancestor. So the incidence of birth defects in children born to non-consanguineous first cousin couples is represented in this table here. This is an old figure, but also there are some caveats to it, but nevertheless, let's go through that first. So let's say there is first cousin marriage. What's the incidence of first birth defect in SIPSHIP? So there is a 36 in per 1,000 chance of there being a birth defect if there is a first cousin marriage. If a birth defect has occurred in this couple, then what is the chance that it could recur in a subsequent child, and the recurrence risk is 68 per 1,000, so it doubles. So similarly, in non-consanguineous marriage, the chance of there being a first birth defect, so they don't have an identifiable common ancestor, but still there might be genetic defects within the same gene in the both the couples, so both the male and the female in that couple. However, if we know that it has occurred once, then the chance of it happening again doubles, so it becomes 30. The risks, especially for autosomal recessive conditions, are considered high in children born to consanguineous couples. And in this table, it's not just depicting autosomal recessive, it talks about all birth defects. The above figures, however, may not be accurate representation for all populations. So it's not been passed for different types of ethnic populations. So there might be different figures for different populations. So we can't use this figure to cancel all of the patients that come to us. Each condition, depending on inheritance patterns, has varied risks. Individual analysis and counseling is recommended for specific conditions. What are the reproductive options should a person know that there is an increased risk for a future child who, based on their own genetics or the genetics of something that is going on in their family? Say that they've got an autosomal dominant condition and there is a 50% chance of their child having the same thing. So what can they do to decrease the risk, or what can they do to prepare themselves? Some couples simply want to know the risk to prepare themselves. They say, okay, what is the chance of me having a child with the same condition? And if we say there's a 50% chance, they say, okay, we're mentally prepared to have a child with the same condition. But some others prefer to prevent having an affected child. The choice depends on various factors, including severity of the condition, family experience of the condition, religious values, and support systems as well. The available reproductive options, if the gene variant is definitely known in the family, are prenatal diagnosis, usually first trimester testing. It involves amniocentesis, which means removing a little bit of fluid from the amniotic sac, or chorionic villus sampling, and the decision to terminate the affected pregnancy. So if an affected pregnancy is detected, if we find that this particular gene problem that's there in the family has been inherited in that pregnancy, then they have to make a decision of whether they continue the pregnancy or then they terminate the affected pregnancy. Another option is pre-implantation genetic testing, which uses IVF techniques. So they collect sperm from the father and eggs from the mother, and they put it together in the laboratory and create embryos. Then they take 1 or 2 cells out of the embryos, and then they do DNA testing, and only unaffected embryos are then implanted in the mother's womb. So this is an option for people who want to circumvent the prenatal diagnosis option. The above techniques, however, are not possible for mitochondrial conditions because it's not easy to test the mitochondrial gene, and also because the mitochondrial gene is only inherited from the mother, it sort of shows up a lot of complications. However, there are some newer techniques, such as using mitochondrial donors, that are being trialed in some parts of the world and currently also being used in some other parts. So it's a space to watch. So we may or may not have further information about this in the future. Of course, there are other methods like using sperm or egg donors, or surrogacy, or adoption, which are also different options that are available for people who would like to utilize these options. We talked about interpreting genetic test reports previously. There is the American College of Medical Genetics and Genomics and Association of Molecular Pathology, ACMG-AMP, who have come up with some criteria to help laboratories to standardize reporting of genetic tests. So previously, if a person had genetic testing in one laboratory, the way it was reported was different to taking the genetic test to another laboratory. So with these criteria, there is likelihood that there is some standardization of the way genetic testing is reported. So when a gene variant is found, we use the likelihood of pathogenicity. So if a variant is categorized as being pathogenic, it means that there is a more than 99% chance that this gene variant is associated with the condition that is occurring in the patient based on various criteria. It could be many things that are being used to determine pathogenicity, such as the chance of this variant being present in general population, the chance of this particular variant affecting the way the protein is being produced or the way the protein functions, or the chance, after trolling through the literature, finding out how many people with this particular variant actually do have that particular genetic problem. So there are lots of things that get taken into consideration, including things like segregation information, which means how many families have been reported in the world where this particular gene problem segregates through the family. So there's a lot of different pieces of information that are all taken together, and then the scientists might determine, based on the ACMG-AMP criteria, that there is more than a 99% likelihood that this particular variant that they've identified in the laboratory is associated with a genetic condition for the person who is being tested. The next category down is likely pathogenic, which means that there is a 90 to 99% likelihood of this particular variant being associated with the genetic condition. So we use both the pathogenic and the likely pathogenic variants to counsel patients that this is the most likely genetic diagnosis for them. The next category is a difficult category. It's called a VUS, or a variant of uncertain significance. It means that there is anywhere between a 10% and 90% chance of there being an association. It means that it's really uncertain. The amount of evidence that is currently available is variable, so the scientists cannot, with the current evidence available, categorize it as being likely pathogenic or likely benign, and that they park it in a separate category, waiting for further information to transpire in the future. So the further information might be testing a number of family members if there are a number of family members who are affected, and if the gene problem segregates in all of the affected family members, then they may be able to then say that this is likely pathogenic. Or if it does not, if it negatively segregates, so affected people don't actually have that gene problem, then they might downgrade the variant and call it as a likely benign. Or it may be parked to wait for further research evidence, like animal studies or something like that. So the variant of uncertain significance is a difficult category to counsel the patients about. We say that, look, there is a gene variant, we really don't know what it means. This might be what actually causes the genetic problem for you as well as for your family, but we cannot use this genetic test to test or predict the presence of the genetic problem in other family members. We cannot use this variant to make reproductive planning for family members either. The next two categories down, likely benign and benign, is that they've just found that this is present in a lot of unaffected people, or just does not affect the protein in any way, therefore it does not cause the genetic problem. So genetic testing reports are not as easy as just interpreting a hemoglobin report saying, you've got anemia, you haven't got anemia. There isn't a clear-cut, easy cut-off. So these are very complex results, and trained personnel, and usually in a multidisciplinary scenario, discuss these results. So usually we have lab meetings along with clinical geneticists to have a lot of to and fro conversations to determine whether a likely genetic result is appropriate for their patients and how to counsel them about this. So what are the issues to consider in a genetic counseling appointment? As we talked about previously, pre-test counseling is extremely important because, as we've seen, genetic test results can be quite difficult to interpret. They could see they're really looking forward to having a proper result, but they end up hitting a variant of uncertain significance, which gives more questions than answers to these families sometimes. Or it could be that they didn't realize that the genetic test is not just, it doesn't inform just their medical problem, but it throws up all of these other problems that, there might be issues in their siblings, or there might be issues in their parents, and they weren't expecting all of that. So it's really important that we counsel them prior to them signing up for genetic testing, and they, sign an informed consent before undergoing genetic testing, so they don't then come back with regrets after having done genetic tests. As I tell most of my clients, you can't unknow what you already know, so it is best for them to understand what they're getting into before they have the results in front of them. The other thing is positive results, negative results. It doesn't normally work like that. Yes, there are positive results, as we talked about, in terms of pathogenic and likely pathogenic results, but it's not always a negative result. We usually consider it as an uninformative result. So we've done a test, and sometimes we have a VUS, which we don't know what it means, so it's an uninformative result, or sometimes it could be likely benign, but we still haven't found the actual result for the genetic condition we tested the patient for. So it's still uninformative in the sense we haven't found the correct answers for the family. It may be that there is a new gene that hasn't been discovered yet, or we haven't done the proper genetic testing, or there might be something that has been missed in the genetic testing that has been done so far, and with improved technology, it might get picked up in the next several years. We've talked about the variants of uncertain significance, which can cause a lot of problem in terms of certainty within the family, and many people get very confused and disappointed when they have a variant of uncertain significance. The other thing also to understand is there could be secondary findings, because these days we don't test one gene at a time. We test a large panel of genes, either using targeted panels or through whole exome sequencing or through whole genome sequencing, where a number, in some cases hundreds of genes, are being tested at the same time, and the reports are being generated for all of these genes that have been tested. So we're testing a person for a particular condition, but then we might end up finding secondary findings as well. So yes, we looked for breast cancer genes, but we've also included some genes which causes ovarian cancer or pancreatic cancer, and we found that you do have an increased risk for pancreatic cancer. Whilst the patient is dealing with breast cancer, now we're going to have to tell them that there is a secondary finding of this particular gene, which in addition to causing breast cancer, it can also cause pancreatic cancer. So BRCA2 is one such gene. Patients are coming to us because they've got young onset breast cancer, and we've done a genetic test, and we found a gene problem in the BRCA2 gene, and we tell them, yes, this explains the reason for your breast cancer, but this particular gene also increases the risk of pancreatic cancer. So they've got more things now to deal with. Incidental findings are things that they were completely not expecting. It's completely different. So you're testing for cancer genes, and you suddenly find a problem in a dementia gene, for instance. And you tell them, hey, you came to us for cancer gene testing, but there's an incidental finding, and we found that you've got a high risk of developing young onset dementia, for instance. So this throws a cat among the pigeons. So this is why pre-test counseling is really important. Sometimes patients might choose not to find out about any incidental findings. So then we specifically mention to the laboratory, do not report anything that is completely unrelated to what the patient has come to us for. Unless they specifically say, yeah, whatever it is, please let us know. We would like to know all of the incidental findings as well. Then we can relate it to them. But otherwise, we all carry something or the other in our genes, and it's not always useful to find out what we've got, because we may not always have a treatment, or we may not always be expecting that, or it may not even be a priority in the current scenario in our life. And as long as we are mentally prepared, then we can make a decision whether we want to find out now or find out later, or bank that information for future generations to find out. Many patients do this as well. They say, right now I don't really want to find out, but I might wish to find out about this later on in life, or I might wish to for my children to find out after my death. So all of those are right answers, and it all depends on individual patient and their family scenarios. Cascade testing simply means family testing. So if a particular person has got a genetic result, and depending on the type of inheritance, we can then extend the testing to other family members. So these are things that we have to discuss with our patient, and saying, you've got this genetic test and this is your result, but now we would like to open up genetic testing for your siblings or your parents or your children also. So with this, I would stop this lecture. It is a long lecture, and there's a lot to consider about how to translate what we've learned in terms of genetics into the clinic. Very happy to take any questions about this. Please send us any questions, and we'll contact you back with the appropriate answers.